So guys, so we did speak about pre-op assessment. So we've done history. We have spoken briefly about history. So now physical examination. Physical examination. So after history taking, it's gonna be physical examination. And under physical examination, yes, you will describe the patient, how the patient looks, the normal way we've been doing in other departments or in other disciplines, and then do a chest examination, CVS, check the vital signs, that kind of a thing. And then the difference now with anesthesia is that you need to do an airway assessment, which we are going to talk about it, but it's basically assessing the patients. You look at, there are things that you look at to decide whether you're going to have a problem with the area of the patient. Are you going to have a problem doing mask ventilation? Are you going to have a problem intubating? So there are things that you look at, including your Mallampati scoring, your thermomental distance, that kind of a thing. I think we are going to cover that in another video. So you do airway assessment, and it helps you to pre-plan what airway management technique are you gonna use, so that you are not surprised when you get to theater. That's about it in terms of I'm being general. And then investigations. When it comes to investigations, if you have done your history examination and you feel that this patient maybe needs a chest x-ray before they go to theater, they need an ECG, whatever investigation that you want, as long as it makes sense and it's indicated and you think it's important, whatever investigation, as long as it's elective procedure, it's okay. And then so that's investigations. So always remember the components, guys, of a pre-op assessment: history, examination, which includes airway assessment, investigations. The last part is pre-medication. Pre-medication, you'll often hear people say, let's go and do pre-meds. When they say pre-meds, they're talking about pre-op assessment. But to be very correct, pre-medication is part of pre-op assessment. So you're not gonna just go there just because it's called pre-medication. You just go there and then you give medications. You will do all these things. And so the drugs that are normally given, that are usually given, they differ, but the standard ones is, and it depends on your patient. The standard ones is your antacids, things like your H blockers. I think it's H2 blockers, which are in the stomach. So if you block H2 receptors, you are gonna decrease the production of hydrochloric acid, and when you do that, you are gonna sort of like increase the pH of this patient. Remember, an acid has got a low pH, so if you give an antacid, you are trying to reduce the acidity of the gastric content. By doing that, you are trying to say to yourself, in the event that this patient aspirates, at least you're trying to minimize damage from the hydrochloric acid which is in the gastric contents. So that's one of the reasons. So patients are usually given cimetidine. Now when I come to think about it, do they ever use proton pump inhibitors? I'm not sure. I think I need to check that. Do they ever use, because H blockers now are very scarce. So yeah. Another thing that they use, the other drug that they give is GIT motility stimulating or enhancing drugs. Those drugs, the main one is maxolon or metoclopramide. So it helps with gastric emptying, basically. You can say gastric emptying. And let me say gastric emptying. Why would you want to do that? It's because when you have a patient, if a patient vomits during the anesthesia, if their stomach is more or less empty, they are likely to have a lot of secretions and a lot of gastric content actually getting into the trachea and into the lungs if the stomach is empty, as opposed to a stomach that is full. So they give maxolon for that, and then there's benzodiazepines. These, they're given for sedation. If you want to sedate a patient before they go to theater, and also just to reduce anxiety. Basically, it's to reduce anxiety. Some people will be very anxious. They've never been to theater. They don't know what to expect and all of that. And what other drug? What am I forgetting? Obviously, not everyone is gonna get a benzodiazepine, which can be lorazepam. Some people will use different things. Some use midazolam, but the class of drugs is benzodiazepine. I feel like there's a drug that I'm forgetting here. Okay, analgesia. Why would you want to give someone an analgesic or an analgesia before they go to theater? It's because you know that they're gonna experience pain in theater. So if you give them pre-op, you might so it can help you with reducing the number of drugs that you might need to use intra-op, and also the doses, because the more drugs you give intra-op, drugs comes with complications, and so you're trying to either reduce the number of drugs that you might need to use and also their doses, right? Let's say if you give a drug that lasts for 2 hours, if you give it 30 minutes before the operation, it means during the operation that drug will still have effect. So you won't have to use a lot of drugs now to try and control the pain intra-op. Okay, So that's your pre-op assessment, guys. It's very important. And yeah, now this is for elective patients. Now with emergency patients, like I said, yes, you're gonna need to do your history, quick examination, quick airway assessment. But the difference is that you don't have the luxury of asking for investigations, not unless you know that they are very life-saving. They are very, very, very important. And also, part of pre-op assessment is to stop drugs, like I said, chronic medications that can have a problem intra-op, like I said. Actually, we had a patient decided that we couldn't operate because she was given Clexane. So the reason to stop the operation, or for stopping the operation and not taking the patient to theater, is because she had Clexane, and Clexane is not given on the day of the operation. So if the pre-op assessment of that patient was not done properly, maybe we're gonna find out when we're already in theater that, hey, this patient got Clexane. Or maybe we're gonna find out when now the patient is bleeding, the surgeon is complaining that he or she is struggling with bleeding. Now when we flip back, we're like, Clexane. So it's very important, guys. It's very, very important. I think not doing a pre-op is just planning for disaster. And you know, the student, these are the things that we don't really sit down and really try to understand, but it's very, very important. So now, like I said, for emergencies, yes, you quickly do that, do this, and you might not have time to do all these other things, and you won't have a time to stop medications that the patient is taking. Let's say someone was taking antihypertensives, ACE inhibitors, they're involved in an accident, and then they took their ACE inhibitors that morning before they had the accident. There's nothing that you're gonna do about that, but knowing that they took it is just gonna help you to anticipate your dropping blood pressures. And also, you won't really have a chance to pre-medicate them. You might depending how stable they are and that kind of a thing. But even though you can pre-medicate them and give them all these other things, you are still gonna do a rapid sequence induction. This is the major difference between these two. And remember, this elective patient is gonna be a fasted patient. We are gonna talk about the protocol, the fasting protocol. So it's a fasted patient who has not had food, who has not had liquids, maybe for the past 2 hours and all of that. So their stomach is essentially very empty, and the risk of aspirating when you have got an empty stomach is very, very low. It's very, very, very low. So you don't have to do a rapid sequence. So the first about rapid sequence is that you are thinking about aspiration, which I think we must talk about in another video. You are thinking about aspiration. You don't want the patient to aspirate. So the steps around rapid sequence, the ideal around rapid sequence is all about protecting the airway and making sure that the patient does not aspirate. That's it. And we are going to talk about it in the coming videos. So yeah, guys, I hope this paints a nice path for us to now talk about the patient that we had yesterday, or the two patients that we had yesterday. So what are the patients that we have to do an RSI on? Like, these are unfasted patients. So when you are unfasted, you've got a high risk for aspiration. So some patients might not might besides unfasted patients that have been involved in an accident, most of them are unfasted, or all of them are taken as unfasted. So an RSI is done. Pregnant women are taken as unfasted as well because of a lot of things. There are a couple of things as well with them. Then their lower esophageal sphincter tends to relax in pregnancy, and it's easy for them to regurgitate. And then another thing is that they've got delayed gastric emptying. That's pregnant women. Gastric emptying. We are going to talk about these things when you do RSI. Another thing is patients who are known to have diabetic patients, because of their autonomic neuropathy, they are regarded as unfasted as well. So when you're gonna operate a diabetic patient, you're gonna do an RSI. When you're gonna operate a pregnant patient and you're gonna do a GA, I'm talking about GA here, you're gonna do an RSI. What else? Patients that have got things like hernias. There's something called hiatus hernia. So diaphragmatic hernias, to be specific. Yeah guys, let's talk about these cases now.